Hello and welcome to this episode of our Rhinoplasty for Residents and the Foundations of Facial Plastic Surgery webinar series. We really hope you have a great time watching this show.
For me, thank you so much for inviting me and Isolda in this amazing webinar that we learn from the coronavirus to give such training courses. And this is a privilege to share with you something that we already published a few weeks ago. So I think it's a good point of discussion to see what we can do with no surgery. Even though we love surgery, we can see something that we can do with no surgery, which is very actual. So I will start to share my screen, and I would like to share my presentation. If everything is going properly, can you see my presentation?
Yes, we can.
Yes, we can see.
Okay, so first of all, you can see that compared to me, Isolda is a very beautiful woman, and me, I'm so ugly in this picture, so let's keep it. And we go to the topic. So, you see that rhinoplasty can be a very tricky operation. We've discussed, not me personally, but many webinars has been followed by the society, the South African Society, and also by Dr. McIntosh. And we see that rhinoplasty can be surgical and non-surgical, can obvious, but the surgical is a nose surgical reshape. The non-surgical is like a camouflage. We can use HA and filler, particularly the HA, which has the possibility to be dissolved, and then the botulinum toxin. You see that we have a treatment choice. We know that the non-surgical is characterized by a focus tip that is staying in the midline. We stay normally 30% deep dermis and 70% under the muscles, compared to the surgical rhinoplasty, which we all know how it has to be made. So the trend actually is that people are demanding quick results. I don't know in your country, but in our particular area of the country, many people are coming requesting, doctor, can you do the non-surgical rhinoplasty? Do you do the liquid rhinoplasty? They call it in many different ways, but they are not aware that this kind of treatment is a little bit dangerous, and Isolda will show you and me also a very short case that we can have problems. So in the non-surgical treatment, it's true, we have a possible shorter recovery time, but we need to repeat it less significantly, and it's less expensive, but in a way or another, we have to take care about the possible complications of this treatment. In the surgical treatment, we have a little longer recovery time, but the long-lasting result is giving the patient much more satisfaction, and it's significantly more expensive than the other one. So you see that the non-surgical rhinoplasty is a camouflage technique instead of reshaping anatomy. So the necessary tools is the knowledge of the anatomy. So many people are doing this in Italy. Many of them doing filler are dermatologists, but some of them are gynecologists, cardiologists, and somewhere in the world I know that there are also nurses which have been experienced in trainings by doctors by doing this, but we have to remember that knowing the anatomy like a surgeon does know the anatomy of the nose facilitate the possibility not to have the above-mentioned complications. And we also have to have very good understanding of the HA rheology, because not every HA can be injected in the nose, we will see. And there is also a concept which we call myomodulation, which can be used less in the nose, but particularly on the base of the nose, we can have some control of the asymmetrical movement due to the levator labii nasi superior. So you see the structural anatomy. I want to mention this thing. First of all, you see that below here there is a mention of the book that we have done. There are 3 co-editors. Just I speak 10 seconds about that because it took a long effort and long time to get out. But it's a very interesting book where you can find all the guidelines and the complication treatment guidelines, and this book is edited by Isolda, by me, and by Dr. Ali Pilayeshi, which is a very good friend in Holland, which is the president of the Netherlands Society of Plastic Surgery. So you see that here we have one picture that is showing us the skin thickness, which is different from area to area. So if we go in the glabella, and if we go in the anterior nasal spine area, which is the nasolabial angle or we go in the nasal base, particularly in the piriform aperture area. We have different thicknesses of the skin, and we have to take care about that, because even though we use, normally in the nose, we use IG prime material, so a material which is very viscous and elastic and stays in place, it can be visible if we inject too superficial this kind of filler. So skin in the initial evaluation is a main point to target the different areas in order to get a good shape of the nose. Then you see that the skin in different areas has different thicknesses. So whenever we want to, and we will see how we can camouflage also the appearance of the nose to make the nose appear less projected, we have to take care about the thickness in the different areas also, because we have to manage the malar area, we will see, or the lip, in order to change the nasolabial or the frontal boss. You know that in the nose we have muscles. We have many muscles involved in the nose, particularly in the nose apex, which is, we call it the glabella area, where we have the link of the corrugator depressor supercilia of the process that are origin from the bony part of the nose, and then we have a transverse nasalis, depressor septinasi, and to mention the effect that we have on the nose, also the levator labii superiori alla nasalis. Then this is the main point when we treat the nose non-surgically. Sometimes we know that some complication can occur. And Isola will speak about that. There are many papers reporting complication. The most difficult to treat is the blindness. And this is due to the fact that some of these vessels that we see here coming up from the fascia, which becomes the angle of the lateral nasal artery, and then we have the ophthalmic artery from the internal carotid system coming out. They join together in the area more or less of the glabella. Then they give the dorsal nasal arteries, and then the arcade, which is around the lateral crust of the nose, the cartilages. So these particular areas, when we inject and we go out of the midline or we are in the wrong plane, can be embolized by the filler, and this can create, of course, blindness also after the necrosis, the skin necrosis. So we have to keep in mind very accurately our anatomy, and this is fundamental if we want to inject the nose to treat it after an accurate training course in anatomy for fillers. So you see again, you have this area which is in the circle of the red circle, as you can see here. Again, there is the anastomosis of the ophthalmic artery coming from inside and of the external carotid system, which is from the outside. So vascularization, sometimes the midline that we mentioned is not a warranty to get the proper results, because you see that this columellar artery is becoming one and then splitting in two. This particular case that we pictured while we were making the pictures for the book. And we have to remember that not only the midline is fundamental to treat the nose, but we have to keep in mind the depth. So the layer where we are injecting is very, very important. The innervation is not so important, away from the fact that we can inform the patient about the feeling of numbness that can result from injection in the surrounding areas of the nose, particularly in the piriform area, where they can feel some kind of numbness in the upper incisors, and they can feel a little bit of numbness in the area, in the medial area of the malar or inferior orbital area, as we say. And this can be bothering them for 30-40 minutes, but then this will go away, because the lidocaine, which is normally dissolved inside the HA gel, is 0.3%, so it's very easy to get the resolution of this thing. And here you see that whenever we want to create like a more effective numbness, for example, if we want to treat the dorsal part of the nose with a canula, we have to get the trigeminal nerve, get some numbness, so we can inject over these nerves, and the infraorbital nerve, as you can see, they are described very well from the midline. We know supratrochlear is 1.4 and supraorbital 2.4, 2.5 centimeters. So I don't want to stop too much on the cartilage and bone, because this is more a surgical issue. but it's just to remind people the relationships between the cartilage and the bone and the soft tissues that are the area where we are going to inject. Just to remind us that whenever we want to camouflage the nose, we have to know accurately where to position the filler, because the filler will change the shape of the cartilage or of the bone. And some words about the occlusion. I'm maxillofacial surgeon as well as ENT, so I care so much for the occlusion, not because we have to change the occlusion, but because when we speak about the nose, we speak about also the profile. So whenever I look at the nose and it's over-projected or it has a different nasolabial, like unpleasant nasolabial angle, we have to change it, but we have to take care about the teeth exposure, which means how much the teeth is exposed when we smile, because when we inject the piriform aperture, the smile can be lower, so the upper lip can be lower. And then also about the drooping of the tip when we smile, if there is a much more protruding anterior nasal spine because of an overjet, which means that the upper incisors are more inclined externally, we have to manage with injection laterally to the anterior nasal spine in order to not to get a too open nasolabial angle. But this is a topic of the clinical analysis which we will see. So normally Arthur Swift is used to say that we have to be very careful between the two intercanthal lines. So we have to be twins between these two paramedial lines and sisters lateral to the paramedial lines, because as you are all aware, when we treat the nose, every patient will notice every little tiny defect, every little tiny shadow in this area. So we have to be very careful when we inject even small amounts of filler, because the filler doesn't move, can be moldable a little bit, but if we create a bad shadow, this can distort the nose and we will have to dissolve it with the hyaluronidase, which is very quick, but we have to redo the treatment. So you see that we have some words about the terms. We have forehead prominence, which can influence the prominence of the nose, the nasofrontal angle. Nasal dorsum, supratip, breakpoint, and columellar labial angle are all details that we have to take into account when we analyze the nose, particularly from the point of view of the angles, because the forehead can influence the profile view. If we go out of the 13-15 degrees in the female and 10-12 degrees on the male patient. The other angles I don't mention because it's a long time that we are discussing the nose surgery, so we are all aware about these angles. And these measurements are coming from the position of the teeth, which I don't want to stretch. This is a facial grid that we publish in PRS, which is a good method to trace a midline and two intercanthal lines. These lines with the crossing lines horizontally from the mid-pupil and then subnasale and many another two on the nasal tip and one in the midline, in the midpoint between the glabella and the nasal tip, are very useful to take records of what we are going to inject in our patients. But please remember that we are in the midline, so left, right, nasal base, and whatever. It's just because we inject in the midline, then we mold the material laterally with our fingers. It's just to take records and customize the treatment for the next time. We have a grading. If we look at this face, it is very easy to make a tiny correction of this nasal shape. We should say that it's okay, but if we look at the normal measurements, we see that the eyelashes are a little bit forward compared to the glabella position. So to get a proper profile in this nose, we should have a little bit more projection in the forehead and the frontal bossing here, and a little bit in the glabella in order to have a straighter nose. This is very easy to treat. This intermediate difficulty because it's over-projected nose. But why this is all projected? Look at the occlusion and look at the malar area. Infraorbital area is defective because of the age. She is defective because of the development during her process of growing and during aging. So here is so flat and the nose looks overprojected. Together with that, we lose some tissues in the upper and lower lip. So the chin is protruding, the lip is going backwards, the occlusion is backwards, so the nasolabial angle is open. The nasal base is retroprojected, so we need to get some more protrusion in order not to get an overprojected appearance. This is difficult because of the scarring. So whenever we have a treated nose, this is a topic we can discuss. It's a problem of looking for complication. We don't have to treat noses which have scarring like this. This is very difficult and can get the proper way to get a complications. And this is clearly impossible. This is a big trauma that was reconstructed in a way or another in another hospital. Then we made a forehead flap to reconstruct this nose. This is not possible to inject at all. So let's look that the surrounding bony support we have seen is creating a different appearance of the nose. If we move forward the maxilla, you see the nose enlarges and it is distorted by the different position of the nasal insertion. So this is true also when we age and when we inject in the wrong places. So you see the anterior nasal spine, for example, the retraction or the loss of muscle and the thickness in this area gives us shortening and thinning of the upper lip, as you can see here. So we have a very open nasolabial angle and an unpleasant drooping tip when the patient is over 45-year-old. If we go here, the anterior nasal spine has been advanced with a maxillary advancement, so the nasolabial angle now is open. So you see that when we give too much support here, we are able to open this area, particularly if the soft tissue is so thick, because this is a 24-year-old female. So you see again, the upper teeth is just giving support in this very nice patient result. You see that advancing the upper maxilla and recreating with the plumping graft in the infratipulobula and one graft on the glabella. This is cartilage graft, of course, but it's just to show what we can change by moving the hard tissues in order to support the soft tissues. And the loss of the upper lip support in this different case is giving an enlargement in this area of the nasal base, which has a relationship that you can read here from Rednish paper. And this is something that some patients are asking because they are not aware that we cannot give the nose a little bit straighter appearance if we have a situation like this. And again, the ascending process of the maxilla, if we put forward the ascending process of the maxilla after 15 years, you see that this patient is still having a good projection and a good shape of the nose after the grafting of this area. And again, here in the anterior nasal base, the piriform aperture has been advanced with the med-pore grafts together with the bimaxillary advancement. So when we manage our soft tissues, you see also in the malar area, we can change the shape of, like changing the surrounding areas, we can change the shape of the nose. Can we use needle or cannula? It's a good discussion, but making it simple, normally I use always the needle, and we will discuss about that, but I use the cannula when we have big voids, which means that if I have an Asian patient or a black patient, sometimes the nose is so flat and we need to inject about 1 ml of filler, so it is not necessary to make multiple holes along all the way. We enter between the domes with the cannula, just with some numbness here, and then we insert it like rotating this until the top and then inject the retrograde and not go back again by taking the advantage of the numbness of the gel, which has lidocaine. So you see here is a scheme that simplifies that we use the needle in glabellops, all the areas with the needles, but the cannula is to make it simple in big voids and wide asymmetries and thin skin. So we have the advantage of one single entry point with the cannula, so less bleeding if we wish, and multiple points injection with different depths if we don't go in the proper plane, and you can mold it very gently when we use the needle. Which sequence do we use? So we have to remember that we have, as we all know, we have major tip support mechanisms and minor tip support mechanism, which we already examined in the bony support. And here we see that we have the medial caudal foot plate attachment to the caudal septum. This we cannot distort with the surgery, but we can distort it if we inject in the wrong place our IG prime filler, because it stays in place, it's very viscous and cohesive. So we have to take care about this tip support mechanism to recreate those ones or to emphasize this mechanism with the filler. So our sequence, which has been published here, as you can see, and we can read it in this paper, is first of all, we inject the nasal base. So anterior nasal spine is first point because we have to manage the nasolabial angle. Then we inject the right nasal base and the left nasal base, and then we get numbness of the tip a little bit. So then we go in the infratip lobule with the needle deep between the cartilages. Then we inject the nasal tip if necessary to give a little bit of projection and eventually some supratip break, then the glabella, and finally, only finally, the nasal dorsum, because if we start with the nasal dorsum, we will run after the projection of the nasal dorsum with injection of the tip, and we will have eventually an overprojected appearance, which we don't like, and we have to do everything again. And we have to remember that injecting the nose is prone to complicances, and so we have to take care about one single shot. We do it and it's finished. I spoke about the material. You see here that we have materials with low and high G prime or intermediate G prime. This G prime is influencing the tissue integration and the water absorption. So the highest the G prime, the lowest the water absorption, the highest lift capacity, and a little bit of malleability, so we can mold it a little bit in place, but it stays there because it's very cohesive. So how to make the nose look more projected? You see that we can inject these 3 points to change the nasal dorsum. I'm showing here you the Photoshop illustration for the patient, and then the final result, which is the more right, the right picture that we can see here. How to make the nose look less projected by injecting the malar area and then injecting the from aperture. As you can see, all these points have been taken into consideration, as well as the chin and the malar. So in order to reshape the entire profile to give the patient a good nasal shape. Here we wanted to change the shadows in the glabella and a little bit on the tip and the infratip lobule and the nasolabial angle. As you can see here on the frontal view, we injected different areas to get a proper result. This is immediate post-operative, post-injection, because you see there is still some redness in the nasal dorsum. And this is how to camouflage the nose by looking around the face and making a better harmonic result. So the nose reshaping is with the sequence that I show you. This particular picture coming from the book, I think is always almost crying with me because we have worked so much on these pictures and the schemes. And it was like our topic at 2 a.m. in the Saturday and Sunday evening, also on holidays. But this is the anterior nasal spine. You see that there is a rich network here. So the rich network means that if you are not touching the bone, you can take the risk to have an embolization. Embolization doesn't mean only that we have blindness. We can have also like skin necrosis and big pain of the patient. And losing one patient like a normal facial plastic surgery means that you are losing 10 patients. So you have to be very professional, first of all, not to create any kind of damage, and then to make a comfortable result and to deliver it very safely. So this is anterior nasal spine. As you can see here in the video, you see that we can insert in the area the cartilage graft, as you can see in the surgical part, but the same is in the same area. You put the IG prime material between the fingers, you hold between the fingers, you touch the bone, aspirate. Aspiration, even though there are controversies about that, and we will discuss about this with Isolda, is something that is very important. There is a paper that's been published recently where they say that only 2 seconds is enough to make the aspiration. I don't agree with that. I think that 5 or 6 seconds is enough. But we have to wait a little bit because the material is viscous, and if we have a priming of the needle, we don't know if the high viscosity gel is preventing the aspiration of blood. So this, you see, has changed a little bit the nasolabial angle in this very nice female, and then we see the before and after that we will see at the end of the videos. Has created the first point of injection for our patient. This is the sequence of the right and left nasal base, where you can see that we have a syringe touching the bone. This is one of the most painful places because the patient experiences like a shock, like electricity, in the area which is very much innervated. That's why they feel numbness in the upper teeth, incisors. So here we inject normally high G prime, but then we aspirate and we inject like putting the cartilage graft, as you can see here, that is inserted by a small cut inside. The same we get with the filler, you see. We touch with the fingers, we go in, we touch the bone, aspirate, and then normally in this area, I forgot to tell that the anterior nasal spine is between 0.2 and 0.4 of this filler. This area is between 0.3 and and 0.5 because it depends on how much projection we have to give to the nasal area. Then we put our finger, we disinfect very accurately before and after, and then we wait until we have a complete no bleeding area. Otherwise, we have to run after the bleeding area, the area that we are injecting the patient in stress. So then we go to the infratip lobule, very high vascularized area. So we stay intradermal or subdermal. We don't want to go in these very small vessels. We always use, as you have seen in the sequence slide, the 27 gauge needle, 30 millimeters length. And we inject between points, like if we want to make like a shield graft or whatever the graft we do with the cartilage, we go with we hold between the fingers, so we compress the vessels, then we stay in between the domes, aspirate, and then inject a very small amount, which runs between 0.1 and 0.3 ml in this area. If we see some blanching, this doesn't mean that we are injecting like here. It's because I'm holding with the fingers, then I clean, I disinfect, and then I release my fingers, and you will see that after holding a little bit, not to have bleeding, the vascularization comes back. This is the nasal tip area and the supratip area, which we go in between the domes. As you can see, the needle here is in between the domes. This is an avascular area. So we have some ligaments above our needle, and we inject about 0.1 and 0.3 in the tip, sometimes a little less, because we don't need to have a big reshaping of the nose. It's like some kind of smoothing the angles and smoothing the shadows. This is the video where we quickly insert our needle. Again, we aspirate in this avascular area, and then holding with the fingers, in order not to have displacement of the gel, we inject. You see that there is a swelling of the tip, then we extract the needle and we mold the tip, and this is the projection that we achieve with this technique. It's kind of strange when we are used to make a surgery on the nose where we are going to measure like millimeters of everything, and we are going to be so precise in our result because it has to be stable, and we don't want to get back to make touch-ups in the surgeries. But this kind of treatment is very interesting because we can get very good results. For us that we are surgeons, sometimes there can be very good satisfaction for the patients. This is the most tricky area because we are close to the anastomosis that we discussed a few minutes ago. You see that we are elevating the nasal mass where we have the vessels, and we are touching the bone, and there we can inject, depending on the projection of the forehead, the frontal bossing, we are injecting about 0.2 to 0.5, depending on how much projection we want to achieve. This is an area where we have to remember that the broad tip aesthetic gland can be distorted. If you don't hold tight with the fingers and inject small quantities, probably it's better 1-2 times, even after 20 days follow-up, because if you enlarge too much this area, the broad tip aesthetic glands will be unpleasant, and we don't like the nose, which will be not so much projecting, but it's like when we do the surgery and we don't resect appropriately this area. And this is like a nasal glabella graft that we are inserting. The same we do with the filler. You see, we are touching the bone, we are aspirating, and then we are like holding between the fingers and injecting the planned amount of the filler that we want to inject in this area. And the nasal dorsum, as you can see here, we can go with the needle or with the cannula, as I mentioned, between the domes. You see the two different connections here. And by injecting this area, we are refining, so making touch-up of what we have achieved with the previous injection. And this is, let's say, a kind of nasal dorsum cartilage graft, which I plan to put in between a layer of collagen membrane with some crushed and some diced cartilage. And this is what we do with our filler. Again, we touch the bone or the perichondrium, we aspirate and then inject a small amount and mold it. So if we want to deproject the nose, we have seen that if we give projection on the surrounding areas, like with the malar area or with like we do in the video, we aspirate and then we give a little bit of different curvature on the malar area and the infraorbital zone. The nose is looking electroprojected. But this is also happening if we inject the lips, like you see here. Here we change the filler. it's intermediate G prime or low G prime as the one that I'm holding here. So different concentration of filler means that they are a little bit lighter than the one that we use in the nose, because we want not to have nodules, and we have not to see so much protrusion of these areas. So if you see here, also the chin can be addressed by high G prime or very high G prime filler, as you can see here. And this kind of treatment, you see, is not painful, can be painful a few days after, but it's giving us a very proper result. This is the result that you can see. Let's analyze the broad tip aesthetic lines. You see the tip defining points are kind of a little bit asymmetric because there is a protrusion of the left dome, particularly of the cephalic part of the left crura. But in total, if you see the jawline, the nasal dorsum, the nasal base, and the projection of every different angle has given the patient, without any kind of surgery, a better appearance, particularly on the jawline, the chin, the lips, and the nose, which is still overprojected, but it looks less overprojected than before. Look at the three-quarter view, also the jawline, the lip, nasolabial angle, the chin projection, the glabella, and the infraorbital area. So post-treatment, I normally recommend, but Isolda is more precise than me, which show us what to do. No sun, no sauna, no sports, no alcohol, no eyeglasses. It's a kind of boring life, but we have to observe these things, because otherwise, as in surgery, we can have problems. So if in surgery I tell you don't wear eyeglasses for 1 month, this is the indication for the filler. So complications will be a topic that Isolda will speak about, but I don't talk about anything here. They can be immediate or not, but I want to show you just the slide. This is the vascularization. This is the video, which is showing us the artery coming up and the anastomosis between the internal and the external carotid system. We move the globe laterally, and we show where the embolization is going to happen, going to occur. And this embolization is so scary because, of course, in the literature, there is only 1 or 2, to my knowledge, cases that have been partial or complete resolution. And you see here the ophthalmic coming out. And this is what we should do with the cannula, 50 millimeter length. We can go in and then inject about 1,500 units of hyaluronidase. But Isolda will speak about this accurately. I just wanted to show you a very quick case, because I discussed with Isolda to show this. This is one of my nurses, and she asked me, I want to straighten the nasal dorsum. I had 0.2 ml of intermediate G prime filler, and I said, okay, I do it for you. I've done it. And after some minutes, she became bluish, like this. So I thought that it was like a kind of hematomas, but being not sure, because the hematoma was going down to the cephalic point, part of the lateral crust, left lateral crust. I high laser for many times. I keep her under observation. This is the day 2. You see that it's starting suffering. The skin is suffering again. You see after day 3. Day 4, you see the typical vascularization of the area. This is the skin suffering after the 5 days. This is day 6. Day 7, she's recovering. And day 10, no problems on the nose, but it's so scary. So this was my mistake, you have to know, because this was surgically treated, and I gave it like a favor to her, but it was so not observing the indication, the international indication. Now there are much more clear indication. This was 5 years ago. So just a very quick 2-3 clinical cases. I think I have still 4 minutes, and this is 22-year-old doctor. I want better lip and nose. This is a small hump, overprojected nose, defective infraorbital area, underprojected upper lip, nasolabial angle too open, and the chin is defective. This is the result after, with the symmetrization of the jawline. The nasal dorsum is still some kind of asymmetric on the right side. You see I injected too much in the glabella in the right side, so it's the broad tip aesthetic line is a little bit distorted. The nasal tip is okay. You see the profile view is much better projected, and there is better harmony in this area. And this is the 3/4 view, where you can see that the solution for the patient was really something very easy to get in 40 minutes of non-surgical treatment. And this is the patient the day after, no hematoma, and she's smiling, she's moving very well the muscles, which is our aim. And this is after another injection 3 months ago. So this is another case study where we have an overprojected nose. The nasolabial is very bad, close angle, 90 degrees. The chin is retroprojected, but the labiomental circus is not pleasant, and the upper lip has to be changed, as well as the glabella and the frontal bossing and the forehead depression. So we injected her in these different points with intermediate and high G prime and very high G prime material, and as you can see the profile view where the nose appears to be better projected, as well as the jawline and the lip projection. And this is the patient the day after the injection. And the very last case I think that we should discuss is this very defective chin with a little bit of broad tip aesthetic lines asymmetry, particularly on the left side. They are different. I tried to create a symmetrization of the broad tip aesthetic lines. You see that we have like an asymmetry of the nostrils, but we cannot treat the nostrils away from the fact that we can inject the nasal base more material on the left side, and we can camouflage this area. Let's see what happens. So we treat the patient in different areas with different materials. As you can see, the different colors means different high or low G prime, and this is the result. So I injected more on the left nasal base, so the nostrils now appear a little bit more symmetrical. The nasal dorsum has been injected to recreate a better broad tip aesthetic lines, and the glabella also has been injected, as well as the forehead, which appears more light on the flesh. And the chin also is no more contracting, and she has support to the lower lip. She appears more relaxed. And the nasolabial angle, as you can see, as the chin projection and the nose has changed, as well as the infraarticular, which we injected to recreate a better shape of the nasal area. So I think that I'm almost done because it's 40 minutes. So I think that if there will be questions, we go after the, I don't know how to manage. I thank you so much. I hope it has been interesting, and it will stimulate some discussion after we have finished.
Dario, thanks. Yeah. Dario, thank you very much.
We have time.
Sorry?
I say, Dario, this is very interesting. Please carry on a little bit longer. It's an opportunity for us with you. So carry on. Dion will ask you some more questions as well.
Okay, so I have some more cases to show if you want to see. Let me see. Yeah, this is the patient the day after. This particular patient was a little bit swelling on the chin because we injected a very high G prime material, which this patient was so sensitive to. And she had swelling. She was so worried. Sometimes we have to take care about that because now we already published a paper on some codes and some constant numbers that we use in our patients. Constant numbers means that we inject a special amount in every special area. So we customize the treatment, but there is a minimum of amount of filler and the specific G prime that we have to use. In this particular patient, she was a little bit complaining about this because she felt like for 5-6 days a big pain in the area, like a surgical treatment. But we don't have to think that when we treat these patients, we are doing some kind of, let's say, injections. It's a kind of surgical treatment because we are going to inject, in this particular one, we injected 13 syringes. So this means that the cost, biological cost and economical cost, is like close to a surgical cost, depending on how much you make the patient pay. But this particular treatment costed about 10,000 euros, so it's about more or less $11,000. So it's a kind of making the malar, making the chin, making the nose, and making the forehead. For surgically, it's much more expensive, but it's a number. So if you see this male patient where we want to change the labiomental circus, and then we want to change the glabella, so you see that we want to make this nose look less projected. As you remember, we want to reshape the forehead, reshape the glabella, reshape the malar infraorbital area, reshape the lip and the chin in order to protrude everything and make the nose look shorter. So you see, this is not a perfect result, but it's very easy result to get. And this is again the superimposition of the pictures to show where we change the patient profile. And this is the frontal view where we change the differences, and we see the differences in changes that we have done. This is the reporter view where you can see that the before and after are showing us a very, very natural result. I aim for natural result. I don't want like distorted anatomies and distorted aesthetics of the face. This is something that we don't like, and particularly in Italy, and particularly in this area, we don't want to have distorted anatomies. Another patient, this is a 38-year-old patient. She comes to me for the lips, and I tell her, you have to do the chin, you have to do the jawline, you have to do the infraorbital, and you have to do the nose. And she was like, oh my God, I was like thinking that my face was pretty, but I said with the very tiny amounts of filler in different areas where I make the red dots, you see that we can achieve a much harmonic result. So you can see here that the lips, away from the tattoo that she has that is distorting the lip, not my filler, but the tattoo, she's much more pleasant. Also the broad tip aesthetic lines, the infra-tip, the infraorbital is more lighter. She has no more the tired aspect because we are supporting the orbital muscle, buccularis oculi muscle. And the chin is much more relaxed with no shadows because she has been injected. You see also in this three-quarter view, particularly you see in the area which we call C6 and the JW4 and 5, which is this area below the oral commissure where the depressor anguli oris is originating. So we see that we are relaxing this muscle because we are injecting over the muscle to myomodulate and to reduce the potential contraction of the muscle. So the oral commissure rotates upwards, and injecting below the zygomatic muscle, we are able to have a better contraction in this area, also to have a better reshaping and the repositioning of the oral commissure. So you see that this is a little bit distorted, this picture, because I think that the left one is a little bit smaller, but let's see that there is a change, and we can see it in the three-quarter view anyway, so we don't have any distortion. This is much more reliable, and you see that we have a better projection on the inferior third, as well as the reshaping of the nose by protruding the glabella and the forehead. And this one is a particular case because we have an asymmetry in the nasal dorsum, but we treated also this surgical lower lid deformities. So we see that we decided to inject all these points with different G primes, and this you can see this is the immediate result. Of course, we had some redness, but clearly, particularly on the right side, we have a surgical result just with the fillers, and the patient was very happy, particularly for the lower lid and the nose. You see from the below view the result. You see the side view where the nose was reshaped, and the chin and the lips also, and this is the reporter view. So we have different views in order to show you that we have achieved a very good result. Whatever you look at, it's a kind of surgical one. And I think this is the last case, a 24-year-old, where we have asymmetry of the brows, but the nose has a very protruded glabella. You see the shadow that we noticed there. I think that if we look from the surgical point of view, we have a very wide tip, boxy tip, and we have a very retruded insertion of the nasal ala. So we need to extrude the nasal ala. We need to make the nose look thinner in the tip. So we have to inject more here in the tip and the supratip area in order to make the domes look closer. And then we have to reshape the broad tip aesthetic lines and the glabella. So this we have done. There is a slight hump, and this slight hump can be easily corrected by an expert injector, and by surgery is very easy now with different techniques. And then the chin. So you see here that we have no more contraction on the chin because we injected the chin and it's giving support to the lower lip. Going up, we changed a little bit of the support of the anterior nasal spine, and particularly the piriform aperture has been injected, so the nose is looking more projected and the glabella looks more projected. But if you look at the smile, you see that the nose is not going down at the smile because it's supported by the filler. This is the three-quarter view where you can see that we give a little bit more projection on the nasal tip and the glabella. And this is the profile view where you see the very interesting result because we have changed completely the profile view. the posture of the neck of the patient, because she's supported on the chin, is, believe it or not, is changed because we have a different feedback on the brain about the muscle contraction on the chin and in different areas that we have treated. So, in conclusion, it's necessary to make these treatments with the primary correction. Don't go to surgical cases, because patient with scarring, previous scarring, particularly post-traumatic nosis, can be a very tricky point if we have a complication. We have to be experienced, and we have to use a very high GPR material. And I don't know if this is my mail, if somebody has to write me some questions which you don't remember tonight to make it. And this is the book that we spoke about before, where you can find all these informations and all the videos that are projected online. And it's very interesting because this book also is dedicated to the facial burns patients. So the money we collect in this book will go to this foundation. So now it's really finished, and I thank you very much for inviting me here.
Dario, that was absolutely amazing. Thank you very much. I must say, after a talk like this, all I want to do is inject noses for the next week. So thank you very much. It was inspiring. Everybody listening, we're going to have another 45 minutes. Isolde Heidenreich is going to talk next about filler complications. We've structured it such that all the questions will be asked at the end. Please feel free to submit your questions. Isolde, welcome very much. We look forward to hearing your talk. Thank you.
I think the other screen needs to stop sharing to allow me.
Dario, if you could stop your share.
Okay.
Please.
Oh, sorry.
Okay.
Sorry, I was just checking. Stop sharing. Is it okay now?
Yes, it's okay.
Oh, thank you. Sorry for that.
That's okay.